Today, we're talking about understanding how healthcare is hurting your employees and your bottom line. And we're pulling back the curtain on vertical integration and pricing. And so, just kind of knowing that checks and balances don't exist in the health insurance industry creates a foundation for understanding why our premiums go up so much year after year. And most of us are aware that the Affordable Care Act enforced that medical loss ratio to make sure that insurance companies can't spend more than 80 to 85% in medical claims and in healthcare, but that 15 to 20% that's remaining can be allocated to salaries for CEOs and profits. And so just to know that there's a perverse incentive to increase spending because it really does equate to increased profits with the traditional insurance model. And that's kind of well known, I think, in the industry. But what isn't maybe so understood is how they take the remaining 80 to 85% to capture the profitability out of the medical care costs by using something called vertical integration. And so today we're just really super grateful to be joined by Ben from Self Fund Health. Ben started getting curious about healthcare after being confused about how his wife's health plan worked. And that put him on the path towards learning and discovery that brought him to start up his own health agency, Empower Health, where he learned from the most forward-thinking brokers in the country designing custom self-funded solutions for businesses all over the country. Now with Self Fund Health, Ben is passionate about bringing every business the care that they need in a transparent, affordable manner. Welcome, Ben. We're so hoping you can shed light for us on how vertical integration works, what is it, and give us some examples.
Yeah, thank you. Grateful to be here and support what you're doing down there in Chicago and all DPCs across the state, across the country. So vertical integration, I mean, it's nothing new. I mean, this is something that happens in business. I mean, think about white label products that you go to Walmart or Target and they have their own brands. Walmart has the Great Value brand. And so usually it's a little bit cheaper, than the name brands and even some of the off brands. And they make it very attractive because they own that procurement process, right? They get to purchase more, they buy in volume, they put their name on it, they buy directly from, manufacturers, and sometimes they own them. And so it's nothing new in business. And when it comes to healthcare, you see it all over the place. And so the two biggest places that I think you see it are with the health insurers, which is you've already touched on. And then the other place is with the health systems themselves, with all parts of the care journey. So when you look at those two avenues, starting with health insurers, you have a company like United, right? And like you said, they have this medical loss ratio that they have to abide by where, for every dollar of premium that they collect, they have to pay out 85% of that in claims. So on the outset, that sounds like a great idea. And it's like, yes, we want to limit, how much they make. But then when you realize that there's really no limits on how expensive claims are or how much hospitals charge, you start to realize that the way that they're winning is by inflating prices. Because let's just use an example of an MRI. If you have an MRI that, used to be $600 and now it's $6,000, if a health insurance company is paying a $600, claim out and they technically get to keep 15% of that, that's a lot smaller of a number than $6,000 MRI. And so that's part of the reason you see this, blossoming of just exorbitant healthcare costs.
Yeah, so 15% of a small pie is a smaller number than 15% of a big pie.
You got it. Exactly. Yeah. And so within that, though, a lot of people talk about that as one of the bigger problems, but really, when you look at the big health insurers, so that, you have the Blue Cross, you have United, Cigna, and Aetna. Those are kind of the four main national carriers that carry the most weight, that have the highest volume of insured people. And, you look at a company like United and you have to break apart how health insurance works, so essentially you have the network, right? So that's the contract between the health insurer and the providers or the health systems. You have the TPA, the third party administrator. That's the entity responsible for collecting the money and paying out all the claims during the plan year. So they're sort of like the quarterback of the plan. They're very important in everything. You have the PBM, so pharmacy benefits manager. They're the middleman that sits in between the wholesalers and the pharmacies. So basically, they're the ones that set pricing and contracts and rebates and get the plan set up with how their pharmacy is going to run, what's covered, what's not covered, as far as drugs. And then you have the stop loss or reinsurance on the back end to protect against the big catastrophic claims. And those kind of four entities are what make up health insurance. Now, when you have a company like United, they own every piece of that. So they own the network, right? United has a couple different networks. They have the TPA, right? They own the TPA. They own the PBM, which is Optum, right? Optum RX, among other things. Optum is also stop loss. They also own more physicians than any entity in the country. I mean, they do a lot, right? They're buying independent practices like crazy right now. I think they're up to like 80,000 physicians at this point. I mean, it's incredible how many they have. And then, they have their own stop loss. So when you look at that, they basically operate in a model where, they adhere to this, medical loss ratio, but then on the back end, there's all this hidden revenue and gotchas and gag clauses within their contracting that basically allows them to move money around any way they want and pay themselves along each step of that vertical integration. And so there's really no way to win in that scenario for the consumer because of the way that they hide where their money is going, where the different fees are, things like that. And if you ask them, they'll say, we pay the claims that our network, gives us the best discounts, with the providers and the hospital systems, and we pay our claims really well. And, we're giving you the best price, that's what we're doing. But now in the age of transparency with the, machine readable files that hospitals are required to post, that health insurers are required to post, you see that the contracted rates that they have with hospitals are usually much higher than what you can pay for cash. So then it just sort of begs the question, why do we have these networks? Why do we have these health insurance companies when if you pay a fair cash rate, it's like half the price, if not lower? And there's examples of this, all over healthcare that I'd be happy to share. But I'll talk about the health systems vertical integration at this point. And specifically in my state, which is Wisconsin, this is why you see such high costs in general. We're the fourth highest cost healthcare state in the country. We have the fourth highest costs out of the whole country. And a big reason is because this health system dominated health plans. So Marshfield Health System has security health plans. Aspirus has Aspirus 360. We have, the HMO land with UW and SSM and Dean and Quartz in Madison area. And all of these entities, so these are now health systems that are participating in insuring risk. So basically you're saying, the same entity that's giving the care is also the same entity that's paying the claims, right? So they're not only setting the prices, they're not only hiring the staff and owning their contracts, but they're the ones that are also collecting the premium and paying all the claims for that. They own not just the payment of the claims now, like the health insurers do, but now they own the actual care itself. And I've heard stories all this year about the care in Wisconsin that is just continuing to degrade and degrade. People can't get in to see a primary care physician in the local health systems for 3 to 6 months. I've heard up to a year for a first-time appointment. Physicians are obviously burning out like crazy, and it's super stressful for them to see 23 people a day, 30 people a day, for 15 minutes each. specialty visits are pushed. That's why you see these urgent cares popping up all over the place. The reimbursement rates that a hospital system gets for urgent care visits and ER visits, it's a lot higher, right, than it is for primary care visits. So, well, primary care isn't working, we can't get people in there, so let's just put up all these urgent cares, and we make money, more money doing that anyway, because people have a higher copay deductible that they have to pay for those things, and it makes us more money because it's a higher billable revenue, right?
Yeah,
And so,
I mean, I think those are really key points. I think one of the things that has been going on a lot since the Affordable Care Act is a lot of like mergers and acquisitions and vertical integration. And that's something, they've been occurring at a rapid pace. And this is kind of why that's happening. And then in terms of in the hospitals and, I mean, there's something called facility fees that hospitals can charge when they have a practice inside of them that allows them to generate more revenue as opposed to, and I mean, it's not a small fee when you go to see a doctor inside the facility versus you go to see a doctor outside of the facility. It's a significant fee. I think it's at least $250 from my recollection. So there are definitely incentives for hospitals to buy up and for these larger corporations to buy up those medical practices. And they're perversely aligned incentives. They're not for patients to get better care. And we can see that, like you're saying, the outcomes actually reflect that. Our life expectancy has decreased by almost 2 years in the past 3. I mean, we're losing ground significantly compared to other industrialized nations. We're actually rated the lowest in terms of quality and life expectancy. And we are spending double what everybody else is spending. So, or more, sometimes more than double. So I think all these things are, pretty like supported by the evidence that exists and by the data that we have. I would like you to talk a little bit about pricing in hospitals and what the charge master is.
Yeah. So the charge master is essentially a list of prices that the hospital has set for their services. And so, if anybody, that's listening has ever looked at, an EOB or a bill from the hospital, you're going to see these charges like kind of laid out in line item form. And you'll see like, what, this, X-ray was $1,500, or you'll see these prices on there that don't really make a whole lot of sense. And that's really because hospitals in general, I'm not saying all of them, but hospitals in general are very bad at accounting for where the revenue is coming and what each service actually provides them in terms of revenue. And so it's not run like a typical business where you'll be able to say, if I'm a construction company, we made 40% of our profits from doing decks and from, and then 30% from doing bathroom remodels and, this sort of thing. Hospitals know in general what their moneymakers are. But when it comes down to the individual claim details, they really don't know. And so most of their worry and care goes into contracts with health insurers. And that's why you see all these hospital systems fighting Blue Cross or United or the big carriers, is because they want a higher reimbursement rate for the services that they're procuring. But in general, they just care about total contract value. And that's why a lot of these insurers are buying up independent practices, and why a lot of hospital systems are trying to purchase as many as they can. It's not because they care about the practice. They don't at all. They care about getting the patients in the door, because they know if, let's say Dr. Diaz is going to retire and she's going to sell her practice, and I know that you're going to be one of the good people that doesn't sell to an Optum or a big health system. But let's just pretend, you did. They're going to buy it at a, over the valuation that you want to sell it at, just because they know that your 500, 700,000 patients, whatever it is now can be funneled into their system. And they're basically buying patients,
Yeah, so the downstream revenue that's created from the primary care world is not insignificant.
Exactly.
All of their imaging, all of their procedures, all of those things can be really priced at whatever they set the bar for. So as I understand it, they can price however they want, and it's all just a negotiation from a starting point.
Exactly. And so most of the prices are simply made up. I know that sounds crazy, but it will make a lot more sense if you try to read some of these machine readable files and look at some of these hospital prices that they posted in the age of transparency. You'll see rates that are 3, 4, 5, 600% of what Medicare would reimburse for the same services. And we have a great example of this because we steer in our health plan, we steer from health systems quite often, as much as we can, to independent, primary care first of all, and then independent specialties and surgery centers and that sort of things that has fair pricing and higher quality. And there was a pre-auth that popped up earlier in the year for an injection that was for chronic Crohn's disease. So it's a drug, a J-code drug. So this wasn't billed through the pharmacy benefits. It was billed through the medical side of the plan. And it's only administered, through a hospital, usually because you need a provider there, similar to like an oncology type of drug, right? But it was for chronic Crohn's. So this is going to be happening every month for the rest of this patient's life. And the drug was called Entyvio. You'd be able to tell us what it is, I'm sure. But this drug, we found out, first of all, they couldn't get into the clinic for 3 months. It was a big clinic in Wisconsin, southeast Wisconsin, big clinic system. They couldn't get in. She couldn't get in for 3 months. Needed to start the treatment, as soon as possible. And the pre-auth was for close to $26,000 per month, right? That this was going to cost to get it there. Well, we contacted an independent rheumatology clinic in Milwaukee called Milwaukee Rheumatology, which lo and behold was literally in the same building as the clinic that this health system was going to be infusing this at. And we asked them, hey, we have this drug, we have this patient. And she said, oh yeah, so the Medicare rate for that is, $5,500 per month for that same medication. And she's like, and, we'll just give you a unit cost of every 15 minutes that she's in here getting the drug infused, which turned out to be about another $1,000 on top of that. And so now we're paying, meaning the plan sponsor, meaning the business, is paying, $6,500 a month. Oh, and they also got her in 2 days later to start the treatment. So imagine that. But now
right. So this is the mind blowing, right? Not only is it better care, the cost is a quarter, and it's better care, right? And I mean, that's the bottom line for this is
exactly.
that these companies, the insurance industry has really been doing a phenomenal job in creating record profits, but they are not providing excellent healthcare. And the result is that the employers are footing the bill while the American workforce is getting sicker and less productive, and the fact that there's another way to do this and that you and your group have been working on these solutions for employers to really lower their costs and to improve the outcomes, to improve the productivity of their company, to improve the health of their employees. I mean, that's phenomenal. So tell us a little bit about how self-funded health works at your company and how you kind of solve for these issues. You kind of alluded to it a little bit with this example.
Yeah, well, the simplest answer is that we allow businesses to purchase healthcare the same way that they purchase any other good or service. So, the same way a steel manufacturing company or a machining company would purchase steel, right? They don't go to the vendor and say, hey, I need, 10 tons of steel and just bill me later and I don't care what it costs. They're going to figure out what the price is, what the quality is, where it's from, is it a trustworthy partner or not? But when you're dealing with healthcare, you don't get that. You go in and you get service and you get billed later and it's 10 times more than you expect. And you have all the out-of-pocket expenses and, it's a huge mess. Patients are getting sued all the time. 100 million Americans have medical debt. There's a lot of issues with the way that it's currently structured. And so the basic principles of economy, right, that make a free market system, if you will, or capitalism work, right, where you have transparency in pricing and quality before the purchasing decision, we're doing that same thing except for healthcare. So I'm not saying that, health systems should be burned to the ground and, replaced by something else. I just want them to charge more fair rates. And when there are services that can be steered away for certain things, which about 70% of all healthcare is shoppable, is plannable, right? then I would love for that to be able to happen. And so that's all we do. We still allow health systems to be covered, but we present as many shopping opportunities to the plan and to the individual as possible so that they can go and get a fair rate. And really, it starts with direct primary care, like what you're doing. Unless the direct primary care physician is independent from the health systems and is independent from any conflicts of interest that would, keep them from just doing the sole thing they should be doing, which is providing amazing care with the patient's best interest in mind. Unless it starts there, then it's really hard in the rest of the care journey to work on referrals, to work on steerage, to work on care navigation, and all those parts. So the short answer is all we're doing is we're simply a health plan that just allows for more shopping opportunities. And when employees are adhering to those shopping opportunities, because of how much money we're saving them, we waive their deductible and their out-of-pockets completely. So employees will literally get free care, right? No cost to them care, because it's saving the plan so much money. So in that infusion example, we saved the plan $200,000+ a year. And so the plan sponsor was like, I have no problem waiving their $8,000 out-of-pocket costs because it's saving us so much. The whole issue with cost sharing and how the deductibles are so high these days is, hey, if we cost share with the employees, then they'll be paying more of the bill of the care and we won't have to pay it. And really the opposite has happened. With uncontrollable pricing, that doesn't matter. And especially when employees are not consuming healthcare correctly, meaning in an educated manner, they just rack up the bill, especially when their deductible and out-of-pocket is met, and it causes a huge renewal anyway. So we're just a health plan that's independent, from the big carriers. We've put it together with aligned independent vendors that are fantastic. No gag clauses, completely transparent, pass-through pricing, just making a fee rather than making money on the actual healthcare. And this allows the plan sponsors to have control over their spending. It also allows them to have access to their data and to figure out, the trends that are going on and where they can assist in cutting spending. And the result is really it gives the employees much better care at a much lower cost.
Yeah. So, data, transparency, and then choices, right? And and the fact that you incorporate direct primary care into the foundation for the plan is huge, because that's where the employees actually get the higher quality care. They get an advocate. It's almost like back when doctors could advocate and had time to advocate for their patients all along the healthcare journey. It's not just in the doctor's office at the visit for 10 minutes. It's beyond the walls, the 4 walls. And so I think that's huge. Thanks so much. I really appreciate you joining us. If people wanted to reach out to you, how can they reach you?
They can email me, ben@selffundhealth.com. Ben@selffundhealth.com. Yeah, I'd be happy to be a resource, answer any questions. Our plan is only in the state of Wisconsin. So if there's people outside of the state, if they'd like resources or just have some more questions or anything like that, I'd be happy to respond, set up a call, and try to help them as much as I can.
That's great. Thanks so much for joining us.
Yep.